Good morning and welcome to Chapter 35. We're going to be covering geriatric emergencies. Be sure, if appropriate, you are clocked in to get proper credit for this lecture. All right, so geriatric emergencies. All right, so geriatric treatment and assessment is the assessment and treatment of patients of diseases in a person of 65 years of older. Geriatric patients are present as present themselves sometimes a very special challenge for healthcare providers. Injuries and illnesses are affected by chronic conditions, multiple medications, and the physiology of aging. Having a clear understanding of how all this works will help you in management of these types of patients. All right, so general considerations. It is very important to understand and appreciate how the life of an older person might differ from yours. It does take time and patience to interact with an older person, so treat this patient with respect. Just as with all patients, when you introduce yourself, you make sure that you tell them your name and that you're there to help them and get their name and use their name in every time that you address them. Make every attempt to avoid what we call ageism. Don't assume anything with the patient that is an older patient. They may be in better health than you. You just never know. So make sure you don't use the ageism fact to begin that wrong foot with your patients, with your geriatric patients. So communication with older adults. Common techniques are speaking respectively, identifying yourself, being aware of how you present yourself and look directly at the patient at eye level, and make sure that you speak slower and very distinctly. Have one person talk to the patient and ask only one question at a time. If you get too many people involved, you may confuse the patient and they may not be able to answer your questions effectively. And then don't assume that all older patients are hard of hearing. Worst thing you do is come up and raise your voice to an older person. They're going to go, "There's nothing wrong with my hearing. Please quit yelling at me." So make sure that you're respectful of that. Also give the patient time to respond. They may want to think about it a bit before they ask you or before they answer your question. Then listen to the answer. Okay, to be the active listener. Make sure that you're actively listening to what they're telling you and also explain what you're going to do before you do it. Some of the common complaints and leading causes of death in older people, hip fractures are a big one. Hip fractures are very common. They're more likely to occur when bones are weakened by osteoporosis and or infection. They also have a more sedentary type of lifestyle and behavior that could lead to pneumonia and also blood clots. All right, so table 35-1 is what you see here. This is common conditions leading and causes death of geriatric patients. Make sure you're pretty up on this. This is a part of the source of the Federal Interagency Forum on Age-Related Statistics. This was developed in 2012. So the changes in the body, the aging process is accompanied by changes in physiological function. All tissues in the body do undergo aging. This happens because of a decrease in the functional capacity of various organ systems. It is normal, but it can also affect the way the patient responds to illnesses. Specifically, the respiratory system, airway musculature becomes weakened, so we don't tend to, elderly patients don't tend to breathe as well as younger patients. The alveoli and the lung tissue become enlarged and elasticity decreases. And also the body's chemoreceptors begin to slow with age. So patients are, susceptible to pneumonia. Pneumonia is an inflammation or infection of the lungs from bacterial, viral, or fungal causes. It can be any one of those three. This is leading cause of death from infection in Americans older than 65 years of age. The immune suppression associated with aging increases the risk of contracting pneumonia. That's why it's advisable for patients that are 65 years or older to get their pneumonia shot. Then you have pulmonary embolism. This is a condition that causes a sudden blockage of the artery by a venous clot. Patients will present with shortness of breath and sometimes chest pain. Signs and symptoms, the patients by the time you get there are very anxious. They may have some chest pain and they're definitely going to be short of breath. You need to manage this as a potentiality of a clot. Look at the individual, see if they're overweight, find out their medical history, find out if they're on any blood thinners. As far as the treatment is concerned, you're going to have to turn this over to ALS as quickly as possible or rapid transport to the hospital if that's all you have for choice. All right, so changes in cardiovascular system. The heart goes through what's called hypertrophies. With age, it gets larger, gets bigger in size. It's a weaker muscle. You remember, it's beating 1,000,000 times a week, so 52 weeks, out of the year, or so you got to remember that there's lots of heartbeats on every day. So therefore, their cardiac output, eventually declines. And also arterial sclerosis contributes to systolic hypertension, which exacerbates these kind of problems. All right, so in the geriatric patient, they're at risk for atherosclerosis. You see in this diagram here, you see the muscular wall, the lumen, and the lining, and you see the cholesterol that's formed on the inside, which ultimately forms plaque, and then you get a blood clot within the lumen itself. There's accumulation of fat and cholesterol in the arteries, so therefore they're at risk of atherosclerosis. All right, so there's also an increased risk for formation of an aneurysm. This is severe blood loss that can be caused when the aneurysm ruptures. Aneurysm is very simply a weakening in the line of the lumen of the artery or the vein. Kind of like if you think of a garden hose, if you have a garden hose that's connected that has a nipple on the end of it, or some kind of spraying mechanism on the end of it that closes it off. When you turn the garden hose, a big bubble forms on the hose itself if it has a weak spot in it. That's the same thing as an aneurysm. So blood vessels and heart valves become stiff and they begin to degenerate. So you get changes in the electrical conduction system that also lead to abnormal heart rates and rhythms. You also have overall venous stasis. This is loss of proper function of the veins in the legs. This can lead to deep vein thrombosis and/or pulmonary embolism. So a heart attack or a myocardial infarction, the classic symptoms of a heart attack are often not present in geriatric patients. They have lived a long time. They may not, feel pain like you and I. So the signs and symptoms of cardiovascular disease may be a little bit different. Specifically, when we talk about heart problems, we talk about how the heart begins to fail because it's getting tired. It's been beating for all these years. So these signs and symptoms will differ whether it is a right or left-sided failure. Remember, right side is the low pressure side of the heart. The left side is the high pressure side of the heart. So the right side is responsible for venous return back to the lungs. So if it's responsible for venous return that comes from your body and it gets weak, the venous blood backs up and it causes what we call pedal or radial edema. You'll see it down in the ankles. Their little ankles are swollen, their wrists are swollen because the right side of the heart has failed. Now versus the other side, which is the left side of the heart, it's responsible for pumping that fresh oxygenated blood that it's gotten from the lungs back out to the body. If it begins to fail, the blood will back up back into the lungs, causing pulmonary edema. So just very, very simple. Those signs and symptoms on the right, just like I said, pedal edema. Usually these people are overweight. They have poor diets, those kind of things. So that's the, pretty much so the signs and symptoms of those kind of folks. Versus the left side of heart failure, the fluid backs up into the lungs, and pulmonary edema, shortness of breath. You may also have what's called paroxysmal nocturnal dyspnea, which is a sudden onset at night of shortness of breath. That's what that means. Remember that tool. That's a good one. That'll impress the doctor when you tell them what it is. Absolutely. Paroxysmal nocturnal dyspnea. This is a sudden attack of respiratory distress at night. Patients awakened up from sleep. All right, so stroke. Stroke is the leading cause of death in older people. It is usually preventable. They have some very distinct preventable risk factors such as smoking, diabetes, hypertension, obesity, and a lack of exercise. Some of the uncontrolled factors can be age, race, and gender. Signs and symptoms, they vary depending on the systems that are affected. It can be painless or it can have some associated pain, that kind of stuff. We'll talk about that. So hemorrhagic strokes, that's the number one. They are less common and more likely to be fatal. So they don't happen very often, but they could be fatal. This is when a blood vessel actually breaks and bleeds into the brain. Then you have ischemic stroke. The ischemic stroke occurs when a blood clot blocks the flow of blood to the portion of the brain. These are usually very treatable, either with the insertion of a stent or more commonly the use of thrombolytics to dissolve the clot and allow it to move away from that area of the brain. If the symptoms occurred within the past few hours, the patient will be a candidate for stroke therapy center. They actually will take them to a center, or you will take them to a center which they'll receive treatment. Like I said, either a stent or thrombolytics. Also, you may have a patient with transient ischemic attack or TIA. It can present with the same signs and symptoms as a stroke. Remember me talking about the aneurysms? Well, that's what's caused by a TIA, where the aneurysm swells and it puts pressure on the brain, but it doesn't break. If it breaks, it's most likely, it very commonly can be fatal or very devastating as far as their quality of life would be concerned. All right, so changes in the nervous system in the geriatric patients, most common findings is changes in thinking, in memory, and also responses to questions. Remember, folks, as you get older, the brain decreases in weight because it actually has some shrinkage. That's right, folks, I said shrinkage. Performance of the, and also performance of most of the sense organs starts to decline because of the shrinking of the brain. Vision. Decreased visual acuity, depth perception, and ability to accommodate life. Also may have cataracts, decrease in tear production, and inability to see up close, which is presbyphobia. Right, inability to see up close is presbyphobia. And also glaucoma and macular degeneration, retinal detachment, and the presence of floaters in your eyes. I can attest to that. Jeez. All right, next one. Hearing high frequency flow sounds becomes much more difficult. Problems with balance also makes falls more likely. Presbycusis is a gradual hearing loss. Again, presbycusis, gradual hearing loss. Heredity and long-term exposure to loud noises are the main factors on these particular problems with the changes in the nervous system and the hearing. All right, so taste. Decrease in the number of taste buds. Patient may lose interest in eating. Touch, you have a decreased sense of touch and pain perception. This is due to generalized neuropathy of the nerves. Decreased sensation of hot and cold. This is very important because these folks may be injured and not even know it. So think about that. All right, so dementia. Dementia is a chronic, generally irreversible condition that causes progressive loss of cognitive abilities, psychomotor skills, and also social skills. There is so many potential causes, but you also need to understand that it has different grades of dementia, and some of them are actually, fortunately, we're able to slow these processes down with certain things that we can do in our lives to make that a little bit less frequent. Patients may, have short and long-term memory loss. They may have decreased attention span. They may not be able to perform their daily routines as normal. They may show a decrease in the ability to communicate, confused. They may be confused or angry. They also may show signs of impaired judgment, and they may not be able to vocalize pain if they, are injured, that kind of thing. Right, so then you have delirium. Delirium is a sudden change in mental status, consciousness, or cognitive processes. It's marked by the inability to focus, think logically, and maintain attention spans. It affects about 15 to 50% of the hospitalized people aged 70 years or older. Generally, it's the result of a reversible physical ailment or metabolic causes. I'll give you a perfect example. A urinary tract infection. Some kind of septic infection will cause delirium very, very easily in the elderly patient. So the assessment and management of this is relatively easy. From the pre-hospital side, you're going to manage the ABCs and transport them as quickly as possible and let the hospital manage the infection. Syncope, there's possible causes of syncope in geriatric patients. This particular slide shows you Table 35-2 that shows you the causes and the description. Assume this is a life-threatening problem until proven otherwise. It is often caused by an interruption of blood flow to the brain. Neuropathy. This is a disorder of the nerves or of the peripheral nervous system. So function and structure are impaired peripherally. So everything out here, okay, all your fingers and toes, that kind of thing. You have what's called generalized neuropathy. The symptoms depend on which nerves are affected and where they're located, whether they're motor, sensory, or the autonomic nerves. Changes in gastrointestinal system, you have a reduction in the volume of saliva, you have dental loss, gastric secretions are reduced, gastric motility slows, And you may also have diseases within the bowel and also impaired liver function. GI bleeding can occur in the upper or lower GI tract. It can result from inflammation, infection, or obstruction. Specific GI problems in older patients include diverticulitis, bleeding in the upper and lower GI systems, peptic ulcer disease, gallbladder disease, and bowel obstructions. Ask the patients about non-steroidal anti-inflammatory. Any type of non-steroidal anti-inflammatories that they're using are bad for the gastrointestinal system, and also any alcohol use. Obtain orthostatic vital signs that can help determine if the patient is hypovolemic. Acute abdomen, non-gastrointestinal complaints. Otherwise, it's not to do with our gastric intestinal problem, but it's an acute abdomen. It's pain. It's very extremely difficult to assess. Most serious threat from abdominal complaints is blood loss. Specifically, abdominal aortic aneurysms, or AAAs, is one of the most rapidly fatal conditions. So, also changes in the renal system. Your kidneys obviously have reduction in renal function, reduction in renal blood flow, and also tubule degeneration. Also, you have changes in the genitourinary system. You have decrease in bladder capacity, decline in the sphincter muscle control, decline in voiding senses, and increase in nocturnal voiding, and also in males, your benign prostatic hypertrophy. So incontinence, it is not a normal part of aging. It can lead to skin irritation and also skin breakdown and urinary tract infections. These are usually a treatable kind of problem one way or another, even if it's treatable from the standpoint of collection versus just allowing it to happen. And you also have urinary retention, where the bladder and urinary tract infections can cause inflammation. In severe cases, the patient may experience renal failure. Right, so changes in endocrine system. We have a generalized reduction in thyroid hormones, which is your thyroxine. Signs and symptoms could be a slower heart rate, fatigue, drier skin and hair, also cold intolerance and weight gain. Then you have hyperosmolar hyperglycemic non-ketotic syndrome, or HHNS, which is a type 2 diabetic complaint. Usually these are in older people. Signs and symptoms are very similar to those as patients that are in hypoglycemia or hyperglycemia, so you need to manage that appropriately with generalized diet changes and also perhaps even insulin support. All right, so changes in the immune system. Infections are commonly seen in older people because of their increased risk of being able to fight infections. They also may present with anorexia, fatigue, weight loss, or changes in mental status. Pneumonias and urinary tract infections are common in patients who are bedridden, and also signs and symptoms may be decreased or minimized because they're older folks that can't communicate with truly how they feel. They have definitive changes in their musculoskeletal system. They have a decrease in bone mass. It's more common in postmenopausal women. Bones become more brittle and tend to break more easily. Joints also lose their flexibility. There's also a decrease in the amount of muscle mass. All right, so you also have changes in physical ability. Strength begins to decline. Ligaments and cartilage of the joints lose their elasticity. And you get a generalized atrophy of the supporting structures of the body. Then some patients also experience osteoporosis. This is a specific decrease in bone mass where the bone becomes actual spongy. It reduces the bone strength and also increases the susceptibility to fracture. You have osteoarthritis, which is a progressive disease of the joints that destroys the cartilage. It promotes the formation of bone spurs within the joints themselves and leads to joint stiffness. It affects joints in the hands, the knees, the hips, and the spine. You also have changes in the skin, the augmentary system. Proteins that make the skin pliable begin to decline. The layer of fat under the skin becomes thinner, and elasticity of the skin declines as well. So bruising becomes more common and the skin tears more easily. Sweat glands also do not respond as readily to heat, so therefore you may have environmental issues where the patient's unable to properly cool themselves down. You also get pressure ulcers. The pressure is from the weight of the body, and it cuts off the blood flow to the area of the skin. A pure example is that as a patient is bedridden, that is in the supine position most of the time. So there's less blood flows to the heels of the feet, to the buttocks, and that kind of stuff. So with no blood flow, a sore develops there. Pad the voids and under any bony prominences when you move these individuals. That way it's providing them a higher level of comfort. All right, so toxicology. Older people are more susceptible to toxicity because of the decrease in kidney function and then the altered gastrointestinal absorption and decreased vascular flow within the liver. Decreased liver function makes it much harder to detoxify the blood and eliminate medications and alcohol. All right, so typical over-the-counter medications can also have negative effects when mixed with each other or with herbal substances and alcohol and prescription medications. Now, since they have issues with being able to manage liver toxicity, this becomes very apparent when they take too much of this medicine to treat common colds or common ailments. Polypharmacy. This is the use of multi-prescription medications by one patient. The negative effects can include overdosing and negative medication interaction. And then you also have medication non-compliance issues. They occur when there's financial challenges, also inability to open containers, and impaired cognitive vision and hearing type of skills. Depression. Depression is not a part of the normal aging, but rather a medical disease. It is very treatable with medication and therapy. If unrecognized or treated, it's associated with a higher suicide rate in the geriatric population than any other age group. There's many risk factors. There's a lot to learn about depression in the aging process. If you want to know more about that, you can go to AARP or refer to the references within your book. Suicide. Older men have the highest suicide rate of any group in the United States. Older people choose much more lethal means than younger victims. Common predisposing events and conditions usually are prominent within the patient before they make that decision. If the patient is displaying signs of depression, it's appropriate to ask if he or she is considering suicide. The GEMS diamond is created to help you remember what's different about older patients. It serves as an acronym for issues to be considered when assessing every older patient. This is called the GEMS diamond. All right, so geriatric patient, environmental assessment, medical assessment, and social assessment, GEMS. So first off, you identified it's a patient 65 or older. E, environmental assessment can help give you clues to the patient's condition that can cause the emergency. Then your medical assessment, make sure you obtain a thorough medical history, and then a social assessment. Older people may have a loss of their social history and may need assistance with daily living. Special considerations when assessing a geriatric patient. All of these are. We talked about this throughout the lecture. Communication, hearing, alterations in consciousness, complicated medical histories, and effect of their medication. So be sure you're aware of this. So scene size up with a geriatric patient. Here we go for this lecture. Scene size up, first part of your assessment. Geriatric patients are commonly found in their own homes, retirement homes, or skilled nursing facilities. That's the first thing. And many older people do still live alone. Access may be hampered if their condition prevents them from getting to the door. So take that in mind, take that note. And then take note of any negative or unsafe conditions when you go into the house after you determine it's safe. Mechanism of injury versus nature of illness. It may be difficult to determine in older people with altered mental status or dementia, so assume both until you rule them out. If a family member is present, ask them or a caregiver or bystanders why he or she called. Multiple and chronic diseases process may also complicate this determination. In your primary assessment, address all life threats. Introduce yourself. This is your own impression. It's your opportunity to shine, man, to earn this patient's confidence that you're there to help them. Assess them for person, place, time, and event. You determine the transport priority. You should be able to tell if the patient is generally unstable or unstable, or what I like to call sick or not sick, in that initial first 3 seconds. Use the APU scale to determine the patient's level of consciousness. Airway and breathing. Ensure the patient's airway is open, not obstructed by dentures, vomitus, fluid, or blood. Remember the anatomic changes that affect a person's ability to breathe effectively. Loss of mechanisms that protect the upper airway can cause a decreased ability to clear their own secretions, so you may have to suction these people. Circulation, poor peripheral perfusion, lower heart rate, irregular rhythms, vascular changes. Man, they're all part of circulation changes. So all these things may make your assessment a little bit more challenging. In transport decision, any complaints that compromise the airway, the breathing, or circulation should be promptly transported to a hospital. So these are load and goes. Anything that affects their ABCs. Determine conditions that are life-threatening, treat them to the best of your ability, and provide transport to priority patients. Older patients will easily decompensate, so be very mindful of that. Investigate the chief complaint, get their history, find and account for all medications. Take them with you because usually there are too many to actually to write down, to look through. Obtain your patient history. Also, if you take your meds with us, we can find out if they're compliant with taking their medications based on looking at the time that the prescription was done when it was filled until today's date, and based on how it's prescribed, you count what's in the bottle, and it'll tell you whether they're compliant or not. Determine early whether there's altered LOC, and whether it's acute or chronic. Collect your sample history, very, very important. You may have to get this from a caregiver. Again, medications go to the hospital and transport them to a patient to the hospital that knows them if possible. That way there'll be a better continuity of care. Secondary assessment, physical exam. An older patient may not be comfortable with being exposed. Protect his or her modesty and consider the need to keep your patient warm. Little folks that get their self-regulating systems, temperature management regulation systems are not what they used to be, so they get cold very easily. Vital signs: heart rate may be lower due to medications such as beta blockers. They may have a weaker and irregular pulses that are very common. Circulatory compromise may make it difficult to feel radial pulses, so consider other pulse points. Blood pressure tends to be higher. Capillary refill is not a good assessment because their extremities are cold. The respiratory rate should be in normal range. Be sure to oscillate breath sounds and then carefully assess pulse oximetry data. Reassessment of geriatric patient very, very often. Recheck interventions such as position of comfort, ventilation as needed, and psychological support. Document all history, medication assessment, and intervention information. All right, so under reassessment, this is table 35-4, talks about geriatric patient assessment guidelines. This is good stuff. This is on slide 68 of 140. Trauma in geriatric patients: normal changes associated with aging create risk and complicated assessments. They have slower homeostatic compensatory mechanisms. They have limited physiological reserves, and they have normal effects of aging on the body. Can cause a lot of trauma for these types of patients, and then they can be exacerbated by existing medical conditions. Physical findings may be subtler and more easily missed, and the healing process is much longer. Older pedestrians are more likely also to have life-threatening complications after being struck by a vehicle. Older people have a higher risk of burns. The risk of mortality is increased when pre-existing medical conditions are there, if they have a bad immune system, and then fluid replacement is complicated by renal compromise. Higher mortality from penetrating trauma than the younger group. Penetrating trauma can be easily cause serious internal bleeding. Falls are the #1 leading cause of fatal and non-fatal injuries in older adults. Nearly half of fatal falls result in traumatic brain injury. Anatomical changes in trauma, obviously changes in pulmonary, cardiovascular, neurological, and musculoskeletal system make older patients more susceptible to trauma. Overall physical condition may lessen the body's ability to compensate for simple injuries. So in the long term, they may pass away because of organ failure because of the trauma that's associated with it. Osteoporosis, we've talked about that predisposes them to hip and pelvic fractures. And then compression fractures of the spine are more likely as well. Brain tissue shrinks with age. We spoke about that. So there's an increase of risk of closed head injuries. Also with acute subdural hematomas, they're among the deadliest of all head injuries in the elderly patients. Serious head injuries are often missed because of the mechanism may seem relatively minor. Other factors predispose an older patient to a serious injury, whether they're taking, medications that are blood thinners, that kind of stuff. So it can be lots of different reasons. Environmental injuries, internal temperature regulation is slowed in the elderly patients, so half of all deaths from hypothermia occur in older people. Death rates from hyperthermia are more than doubled in older people. They can't tolerate heat very well either. Special consideration and assessment, trauma is never isolated to a single issue when you're assessing and caring for a geriatric patient. There's usually more to it than just the trauma. So, scene size up, look for clues that indicate your patient's traumatic incident may have preceded by a medical incident. I always like to couple the two together until medical is ruled out. There's usually something along with that. Primary assessment, life threats, obviously. Control any external bleeding is obvious. Determine the transport priority as soon as possible. Form a general impression using AFCO and GCS. Airway and breathing, if the patient's talking to you, the airway is patent. All right. The patients who have noisy respirations usually have an airway compromise. Older patients may have diminished ability to cough, so we need to assess for the presence of dentures as well so that we make sure they don't cause an airway obstruction. Circulation, drinking alcohol, and anticoagulant medications can make bleeding control very difficult in elderly patients, so they can bleed to death very, very quickly. Older patients can more easily go into shock because of this reason. So patients who were hypertensive prior to an injury may have a normal BP when they're actually in shock. History taking, make sure you do it using your sample. Physical exam performed in the same manner for any adult, but with consideration of a higher likelihood of damage from trauma. Any head injury can be life-threatening in elderly patients. Consider that breathing may also be impaired by this. Vital signs assess pulse, blood pressure, skin signs. Capillary refill is unreliable because of compromised circulation. But remember that also some older people take beta blockers, so their heart rate may be slow. Remember that geriatric patient has a higher likelihood of decompensating. Broken bones are common and should be splinted. Do not force a patient with a joint flexion or a kyphosis into a normal position. Remember, this is usually caused by arthritis and can cause a lot of pain for your patient. In hip and pelvic fractures, avoid log rolling, people. Stabilize pelvises. Use a scoop stretcher. Do something. Do not log roll these people. You're going to cause more damage. You may even cause a massive internal bleed and death if you don't secure it properly. Provide blankets and heat to prevent hypothermia, and then provide psychological support. So assessment of falls. Falls can be caused by medications, cardiac rhythm disturbances, medication interactions. It is important to find out why the fall occurred. Look for the clues from the patient, bystanders, and the environment. All right, so response to nursing and skilled care facilities. Many falls will occur at a nursing home or other skilled care facility, so be prepared for that. It can be challenging. Patients often have an altered level of consciousness, so you cannot trust what these folks are telling you. Ask what is wrong with the patient, and is that a new or different today? So talk to the caregiver. Is this behavior normal for this patient, or is this different? Ask the caregivers. They can give you a lot of information along with the patient's chart that you can get information from. So infection control needs to be a high priority for EMTs because we have methicillin, Staphylococcus aureus, which is MRSA, also vancomycin resistance enterococci, respiratory syncytial virus, and Clostridium difficile. These are all things that you'll find in nursing care facilities and also in hospitals as well. These are nosocomial infections where it's very easily passed from one to another. That's what's called nosocomial. That's what that means. So, be very conscious of that. Make sure you're wearing gloves, you good hand washing techniques, and make sure you're wearing at minimum, some safety goggles. And if you have to, some kind of respiratory protection. All right, so dying patients. More patients are choosing to die at home rather than in a hospital. So dying patients receive palliative care. As you remember, we had a big lecture on this in the ethical and legal considerations for the EMT about DNROs and different types of advanced directives. So be understanding and sensitive and compassionate to these needs. Make sure to determine if the family wishes for the patient to go to the hospital or stay in the home. Most times that 911 gets called in an advanced directive or DNRO patient is because the patient's family has panicked. So if hospice is there, work with hospice. If they aren't there, respect those families' wishes, especially if your patient is unconscious and unresponsive. So it's just a no-win situation if you're there and you try to go against the family's wishes. Let the hospital manage that. All right, so advanced directives, we spoke with this, specific legal papers that direct relatives and caregivers about what kind of medical treatment may be given to patients who cannot speak for themselves. The DNR is one of those. It gives you permissions not to attempt resuscitation for a patient in cardiac arrest. All right, folks, remember, no heart rate. There is no pulse, okay? It does not mean, DNR does not mean do not treat. You're still going to do basic ABCs. If they have an airway, if they're not breathing but they have a pulse, you have to breathe for them until they don't have a pulse any longer. But you will not do chest compressions on them. So follow your local guidelines and your state regulations on this particular type of form if it exists in your state. Elder abuse and neglect, it happens everywhere, all over the world. So any action on the part of an older person's family member, caregiver, or other person that takes advantage of the older person's person, property, or emotional state. This includes acts of commission of acts of omission as well. So either one, the commission of the act or of the omission of the act themselves. Elder abuse is largely hidden from society. Victims are often hesitant to report the problem because they're ashamed, they're embarrassed. The abused person may feel traumatized by the situation or afraid that the abuser will punish them as well for reporting the abuse. This occurs most often in women older than 75 years of age. Abuser of older people are sometimes products of child abuse themselves. Abuse may also occur in a nursing, convalescent, or continuing care centers. Suspect abuse when the answers are concealed or avoided. Suspect abuse when you're given unbelievable answers by anyone involved in patient care. Information that may be important in assessing abuse includes the following: caregiver's apathy about the patient's condition, overly defensive reactions by the caregiver. Caregiver does not allow patient to answer questions, repeated visits to the emergency department or clinic, a history of being accident prone, or unbelievable or vague explanations of the different types of injuries. Also, psychosomatic complaints, chronic pain without medical explanation, self-destructive types of behavior, eating or sleep disorders, depression or lack of energy, substance and or sexual abuse type of history. These are categories for abuse: physical, psychological, and financial. Know that all these are reportable. This is table 35-5 or slide 99. Signs of physical abuse: inflicted bruises are usually found on the buttocks, the lower back, genitals, inner thighs, face, or ears. Pressure abuses caused by a human hand may be identified by oval grab marks or pinch marks or handprints, especially on the arms or around the humerus areas, that kind of stuff. Also, human bites are typically inflicted on the upper extremities and can cause laceration and infection. Check for signs of neglect, such as the lack of hygiene, poor dental hygiene, poor temperature regulation, and lack of reasonable amenities within the home. And finally, regard injuries to the genitals or rectum with no reported trauma as evidence of sexual abuse on any patient. All right, folks, that is the last slide. Be sure that you take this review into account. It's got some good information on it. So thank you for participating in this lecture, and be sure that you clock out to get full credit for this lecture if appropriate for your class. All right, so have a good one, and we'll see you later.